right, Miss Destiny. So what we're going to practice first is a cycle that we call the active cycle of breathing. First thing in this entire cycle we're going to start with is going to be what we call diaphragmatic breathing. So what I want you to do first, we're in this semi-reclined position, nice and relaxed. I just want you to breathe normally, okay? And then what I want you to do is place one hand on your abdomen and one hand on your chest, okay? And go ahead and just relax and breathe. Okay, great. You can take a little break from that hand placement. Now, after reviewing how you breathe, you do breathe more through your abdomen, which is good. That's known as more of a diaphragmatic or abdominal stomach region breathing. Sometimes we find that people heavily rely on their chest, and that's usually less efficient just to maintain breath. And then what I want us to do is we're still going to learn about diaphragmatic breathing. Even though you do have good diaphragmatic breathing, I just want to make sure we're getting it down. So what you want to do is you're going to make sure to keep your hands placed like that, one on the abdomen, one on the chest, and then we're going to breathe nice and slow, deep breath through your nose, and then you're going to exhale nice and slow through the mouth, really making sure to expand the stomach and try to relax those upper body muscles, not use too much of that, just nice and relaxed. And making sure that we're having more lift in this hand than we are in this hand, okay? What I'm gonna do is I'm gonna place my hand on top of yours on the abdomen region, stomach region, and I'm gonna have you breathe into my hand. So my hand should be on top of yours. We're raising both of our hands as you breathe in, and then it comes right back down. And then making sure upper body here is relaxed, okay? So we're gonna do this a few times. I want you to go ahead and breathe in. Perfect, and out through your mouth. Perfect. Nice, one more time. Great, okay, go ahead and relax. As we progress through this diaphragmatic breathing, we're in a semi-reclined position right now, just as a comfortable starting position, but as you improve with this diaphragmatic breathing, you can do it in sitting, even standing. And so you're just making sure that we're incorporating diaphragmatic breathing in just any type of daily routine or activities of your daily living. Functional everyday activities that you do, you can make sure that you're having that one hand on your abdomen, one hand on your chest, making sure you're not having too much involvement of the chest and more of the abdomen when you're standing and doing different types of functional sitting and standing, okay? Okay, so the next part, step 2, we're going to do the active cycle of breathing, which is ACBT. And then what I want us to do is we completed the diaphragmatic breathing, that's great. Now we're doing that thoracic expansion. So what I'm gonna have you do is place your hands on the side here. Now instead of going through your abdomen up and down, I want you to expand into both hands out and expand out and then come back in. So when you breathe in nice and long through your nose, out through your mouth, okay? Let's do it 3 times. Great. Making sure to exhale until there's nothing left. Perfect. Great. Okay, now let's get back to that diaphragmatic breathing just to make sure that you're not getting too out of breath, and we're gonna do this for about 5 to 10 seconds, okay? So we'll do about 3 diaphragmatic breaths, okay? Perfect. Now what we're gonna be trying is what we call huffing, also known as forced expiratory technique. So this is almost acting like you have a mirror in front of you and you're kind of fogging up a mirror, okay? So let me walk you through it. So what we are going to do is mimic that steaming up of a mirror or a window by using your hand right in front of your nose, and then you're going to squeeze out the air like a, and you're going to use those abdominal muscles also to help push out that air, and that will help bring that air out faster and have your throat relaxed, okay? and you're going to do 1 to 2 of these huffs to mid to low lung volumes using your abdominals to force that air out. And then in between each of these huffs that we perform, I just want you to get back to that relaxed breathing state, okay? And just to make sure that we don't have any shortness of breath, I just want to repeat this about 3 times, okay? So what we're gonna do is take a nice deep breath in, have that hand here, and go, yeah, really use those abdominals. Perfect, and then go ahead and just relax and breathe. Then I want you to repeat that cycle back to me, okay?
Okay, so basically we start off with the diaphragmatic breathing, just making sure that I'm using more of my abdominals, kind of letting my hand rise rather than my chest. Then we go into regular relaxed breathing to make sure I don't get out of breath. Then we go into thoracic expansion, making sure that my ribs move out whenever I'm breathing in, and then move in whenever I'm breathing out. Then I go back to relaxed breathing, and then I fog the mirror using the huffing method.
Yes. So what we're doing now is I'm just going to do a cough evaluation and some interventions if I see anything, okay? So I just want you to simulate a cough for me. Okay. All right. So just some background education, okay? So I'm assessing your cough, and the reason that this is important is just to make sure we have good airway clearances. So if we have any buildup, like mucus or anything like that, we can get it out, just to allow for that free airflow into the lungs and out of the lungs. So what an effective cough has is 4 phases. So it's a deep inspiration, take a little pause, then you have what we call a glottis closure. And then we build up that intrathoracic pressure. So just air is building up, creating some tension in there. And then it's creating that intrathoracic pressure in the expiratory muscles. And what that leads to is a really forceful cough out as the glottis opens up, right? So in assessing the patient's cough, what I found is that we didn't have a full deep inspiration in, and we didn't have a full engagement of the abdominal muscles. So she was able to cough on command as requested, but we were unable to clear secretions because of the cough's weakness for that, abdominals and inspiration. And then did you feel any fatigue with that, or are you feeling okay? No? Okay, good. So no fatigue was reported. We didn't have any sort of production, so there's no mucus. It's a dry cough. And then what we found is inspiration was a little bit weaker, so that could indicate inspiration, muscle weakness, and expiratory, like abdominal weakness. Did you have any pain? No? Okay, good. And didn't see any signs of airway collapse. And then we could also use things like peak cough flow. PCF is a simple objective measure of cough strength taken with a peak flow meter or spirometer. So I have the patient positioned in a kind of free state where the trunk can be in flexion and extension. So there's nothing restricting her. So what I want us to do, we did that diaphragmatic breathing, really nice deep breath in, the glottis is closed. Now really expire out. Good job, Destiny. That was a great strong cough. We got 2 strong coughs out of there. So we cued the patient how to take that full diaphragmatic breath in, and then we made sure that her glottis had closed, and then she expired really strongly using those abdominal muscles to push and expel that air out once the glottis forces open. Good job, Destiny. That was great.
Thank you.
Okay, Destiny, so before we move on to actually getting onto the table and performing that postural drainage with percussions and vibrations, I just want to make sure that we're cleared to do so. Is that okay?
Yeah.
Okay, great. All right, so first what I want to make sure of is we didn't have any reported intracranial pressure increases. Is that correct?
Yes.
Okay, perfect. And then have you had any recent head or neck traumas, intracranial surgeries, or an acute stroke?
No.
No? Okay, perfect. So that's all the neurological screening. Just to screen for cardiovascular, I know we don't have any history of severe hypertension or unstable hemodynamic statuses. And there was no showing of congestive heart failure in your past, is that correct?
Yes, that's correct.
Okay, perfect. And then pulmonary edema, and then have you ever had any unstable angina or acute myocardial infarctions?
No.
Heart attack? Okay. So that was cardiovascular, and then I just want to make sure for the GI tract, abdomen area, do you have GERD, which is gastroesophageal reflux disease?
No.
No? Okay, perfect. We're not at high risk for aspirations. Did you have a recent meal anywhere between 1.5 to 2 hours?
No.
No. So I know that we haven't had any obesity reported, and then have you had any significant abdominal distension?
No.
Okay, perfect. Now for the respiratory system screening, have you had any instances of like coughing up blood or anything like that?
No.
No? Okay, good. Let's see. Any shortness of breath or acute respiratory distress?
No.
No? Okay, perfect. And then just some precautions and relative contraindications for the percussion and vibration, just so that you know, percussion is cupping, so it kind of looks like that hand palm shape. And vibration, we applied that on expirations when we're doing this manual technique, and it applies mechanical energy across your chest wall. They are contraindicated, or they do require a lot of caution over anything that's like fragile tissue, if you have osteoporosis, vascular structures, or unhealed bones. Do you happen to have any rib fractures, spinal or vertebral fractures, or flail chest?
No.
No? Okay, perfect. Have you had any severe osteoporosis or long-term systemic corticosteroid use that could cause fragility in the bone?
No.
No? Okay. And then for cardiovascular and hematologic screening, I just want to make sure, have you had any active pulmonary embolisms?
No.
Okay. And then any deep vein thrombosis?
No.
Okay. Are you taking any therapeutic systemic anticoagulants, which could cause internal bleeding possibly if this technique's applied? Okay. And then do you have a pacemaker or an ICD placement site?
No.
No? Okay, perfect. For oncology and respiratory, I want to make sure, have you had any primary bone cancer in the ribs or the spine?
No.
No? Okay. And then acute pulmonary tuberculosis or severe reactive airway diseases like bronchospasms or asthma attacks, things like that?
No.
No? Okay. Let's see, emphysema or large pleural effusions in the past? Okay. Okay, and then just to make sure, I just want to reassure you that regions that we don't typically avoid, or we typically avoid just to, or be more cautious about, is spine and sternum, because we risk bone injury and sometimes like a localized trauma. Bony prominences like the clavicle or the scapula, it can be painful when on contact. And if there's no real benefit that we have of going over those areas, we typically avoid them. Lower ribs in the flank area is going to be around here, and potential trauma to cause underlying organ like disruptions, so like the spleen on the left, the liver on the right, kidneys in the back. So we try to avoid too much direct contact over those areas. Also, especially for women, breasts, any surgical incisions or wounds, this can cause discomfort, also tissue damage, and if you did have any incisions, it could cause a separation of that. So as we're going throughout this percussion and vibration, some safety protocol things we're going to make sure of is just monitoring your vital signs. We're going to look for any signs of intolerance, and just we're going to stop treatment if you start developing any shortness of breath, bluish tint to the skin, severe chest pain, nausea, or cardiac dysarrhythmias. So you let me know if you're feeling any different, a little unwell during this process, and then we just want to maintain a clear pathway to cough and clear secretions during this process into a designated cup that I'm going to give you. Here, I'm going to have you go onto your back. I'm going to put this pillow behind you. Go ahead and scoot forward for me. And then there we go, just like that. Okay. And then Perfect. I'm going to elevate the legs to 12 inches. So we're going to go lateral to the breast tissue just to not create any tissue trauma. And then we want to make sure that when we're performing the cupping technique, we're really cupping our hands. A better view, we've come here. I'm going to cup over this region here. Now we're going to have the patient take a full inhale, and we're going to perform shaking on the exhale. I've just placed the patient upright. So I would have a receptacle. She would spit out any secretions or cough any secretions out. You could always repeat this cycle if there's no secretions or no cough. And then I was making sure to monitor for any signs of dyspnea, any contraindications or signs that would make me immediately need to stop this treatment. So now I'm going to auscultate for the right middle lobe, and that's going to be where the fourth intercostal space is. So what we'd want to start is the sternal angle here, go lateral. You're going to feel the second rib. You go down a little bit, you have the second intercostal space, third rib, third intercostal space, fourth rib, fourth intercostal space. I'm going to auscultate. And then is it okay if I come just under the neckline to hear it? Okay, perfect. Deep breath in. So since the previous sounds, you would want to hear vesicular sounds. You would hopefully, after all of these percussions and vibrations, get a more normal sounding breath sound on auscultation.